Thank you, Larry. Thank you, Dr. Zagar. Thank you for this opportunity. I'm excited to be here. This is something that I really enjoy doing. I am a physical therapist here in Chicago, known for TMJ treatment, anything above the head, really. We do treat the spine because the spine has to be balanced as well, and the pelvis. But I'm going to share my screen here and see if I can, I don't have all the answers, that's for sure, but I do know some things that might interest you. Okay, so Larry, can you see that physical therapy, airway evaluation, myofunctional disorders?
No. Now I can. Let's see. Yes.
Okay. Okay, so I have, this is Physio Partners Renaissance Craniofacial Group. That's my PT practice. That's all the head and neck TMJ myofunctional therapy gets treated there. The Hobson Institute, just so you know, is more for breathing training. So I have different programs for adults, children, and practitioners that want to learn about how to improve snoring and reduce sleep apnea. Anyhow, so this is just a little bit about me. I'm a PT. I studied myofunctional therapy after many years of doing craniofacial work. I also am a Buteyko breathing instructor, so I teach the Buteyko method. I'm also going through the laying knee restorative breathing method, and I've worked extensively with Dr. Mariano Roccabato in Chile. I go every year in January. I have tickets to go this year. Don't know if it's going to happen. COVID is not good over there either. So we'll just have to wait and see. I do teach Dr. Roccabato's work through the University of St. Augustine. I also teach through the American Academy of Myofunctional Therapy. I teach at the advanced course for sleep and TMD. I also teach dry needling. Dry needling is a technique that everybody should know about, because if you have muscle pain, dry needling is something you should try. I was one of the therapists that brought it to the state in 2010. So dry needling is great. So here is a picture of my family. We all have reasons for getting into certain things, right? This is my family. This is my daughter, my son. She's probably 4 at the time. My son Clyde, my husband, and we're very active in Chicago. We ride bikes everywhere. Well, this is my son. Okay, so, years ago, I think my daughter was 4 when I realized there was a problem, and my son was 2. But, cone beams are something that you need to know they're very important. And thank goodness Dr. Zagar and I are able to, I send patients just to get cone beams to get an airway score, a volumetric measurement of this space. Now, this is a very compromised airway for a 4-year-old. So you can see how swollen the adenoids are here. And just the space for him to breathe, very limited. This is different views of it. And you can just see how much swelling was in the back of their throat. And this is my son before real treatment. 4 years old, before treatment, this was the size of his airway. 48.9 millimeters squared for the size that was the smallest diameter. Really, that's too narrow, and you want it to be at least 100 in adults, but that's in the low end. This is at 8 years old. After he had a tongue tie release, and we'll go into that in just a little bit, he had a frenectomy. He had myofunctional therapy after the frenectomy. He did something called GOPEX that we're going to go over, and we trained his breathing. And this is the outcome is a very nice open airway without the need of tonsils or adenoids being taken out. And the volume of the smallest area is 263 now millimeters squared. Okay, and so this is also, I had a double whammy. I had my son and my daughter both had issues. But honestly, it wasn't until the cone beam that I really realized how bad it was. So this is my daughter at 6 before treatment, very narrow airway, 51.9 millimeters squared, should be at least 100. And now after the ALF treatment, we expanded her palate. We also did swimming. We also did buteyko breathing. We also did GOPEX and posture training. And she also didn't need her surgery that they all wanted to do. I had 2 surgeons ready to do the adenoidectomy tonsillectomy. And her airway grew to 241 millimeters squared. So just so you know, that's really why I got in this field. It was my children. You know, I had no idea I was a mouth breather all my life. I had no idea I was tongue-tied, which is something we're going to go over. And here I am, this TMJ PT that gives advice around tongue posture and correct position of the head and neck. And I had no idea my mouth was parted. And this is what a mouth breather can look like, just like this. Just a little parted. It could look very normal, but it is not a healthy thing, especially during growth and development of your child. Okay, so I'm going to go back to the presentation. Dr. Gimignol, which I'm sure many have read many of his journal articles on sleep, disordered breathing, and myofunctional disorders. Well, he was the person who coined the term sleep apnea. So he's done tons of research. He just died last year, unfortunately, but he was at Stanford. He opened the Stanford University Sleep Disorder Clinic in 1972. His interest was in nocturnal hypertension and that it was present with people that snored. That was the beginning of all this. Now, Gimignol persuaded the cardiologist to monitor these things, systemic and pulmonary arterial blood pressure in sleeping patients. And what they found is that as the patient fell asleep, they began to snore. Prolonged pauses happen, which we know now are apneas, and were noted, and they also corresponded with very high elevations in blood pressure, almost as if people were lifting weights during their sleep. So this really got Gimignol thinking, what is going on? And the whole field of sleep began. But he was one that really truly understood function and knew about myofunctional therapy. And this was from one of the Sleep Center conferences in 2014. His takeaways were, we need to start early. We need new treatment. More research has shown that the worsening of obstructive sleep apnea persistence after tonsils and adenoids are taken out. That is still going on. They cut out the tonsils, they create more space, but if you don't train the function, the swelling returns because mouth breathing just causes inflammation. So mouth breathing, we need more new techniques. Mouth breathing is inflammatory. It causes these secondary issues such as large tonsils. That inflamed lymph tissue will have a negative impact on facial growth. If tonsils are kept too long, it will cause irreversible damage. So we need to address the true issues. We need to regain nose breathing, remove obstruction, and enlarge maxillaries. So maxillaries is the maxilla. We need to enlarge children's maxillas, and there's many, many new treatments now for adults even to expand their maxillas. So we also need to recognize short frenums, and pediatricians and pediatric dentists need to be a part of the team. Okay, so this is an airway. It takes an airway approach. You need to have more than just one practitioner. You have to have, I think you have to have a PT, a sleep doctor, a orthodontist, a airway dentist of some sort, a pediatric dentist possibly, an ENT, a neurologist. It takes a lot of people, but if everybody understands what a myofunctional disorder is and how to approach it and what part they play in it, the patient will get the best outcome. Okay, so this was in 2018. This is a schematic around mouth breathing and its negative impacts. The many negative impacts of mouth breathing are summarized in this schema. So you've got a mouth breathing child or adult. It causes local inflammation, causes tonsillar enlargement. It worsens poor nasal breathing and increases upper airway resistance. So then you have systemic inflammation and you have postural maladaptations. And then you have abnormal oral facial growth. So this is a vicious cycle that occurs in so many children that mouth breathe. So many are mouth breathing these days because the diet's not good and there's a lot of allergies that aren't really getting treated properly. And there's no awareness of the mouth breathing. Believe me, if I wasn't aware my children were mouth breathing, and I've been taught mouth breathing is bad from years ago. Rockabato would always say tongue up, lips, teeth slightly apart, lips together, but your tongue forms your palate. And if you don't realize your tongue isn't touching the palate, it doesn't spread it wide. So and I'm an adult that was a mouth breather all through growth and development. I have a high narrow palate. I have 4 bicuspid extractions, and my jaw was set back about 4 or 5 millimeters because of all that. And I had a bent nose. So my deviated septum, until I had a cone beam, I didn't know was covering this nasal passage. So I had a bone spur that was blocking my right airway. And I think it was Daniel Klahr that was speaking at your study club that looked at my scan and said, Jen, you got to go get your nose done. So I went and got my nose done at Dr. Liebert's up in Indiana. And things have been so much better ever since. But this is the cycle that many children go through, and then they become adults that get stuck because they can't really breathe through their nose as well. So this is an interesting study. Oropharyngeal and tongue exercise, that's just myofunctional therapy. This is all around snoring. So you have a systematic review and meta-analysis. And basically what they were trying to do is to show if myofunctional therapy really helped the outcomes of snoring, right? So they had PubMed and Medline. They used 3 different databases to search all these articles. And what they wanted to do is get patients that were children or adults with snoring issues. The intervention was myofunctional therapy. And then they compared the pre and post treatment data for snoring and the outcomes for snoring. And out of the 483 articles, 56 were downloaded. And then they basically had a total of 211 patients. These were all adults. The snoring intensity was reduced 51% in 80 patients from the pre-therapy to the post-therapy visual analog scale, and also the Berlin questionnaire snoring intensity reduced by 36% in 34 patients. Finally, the time spent snoring during sleep was reduced 31% in 60 patients. So there is proof that this therapy reduces snoring. Okay, Zarush Zaghi is out in LA. I know him pretty well. We've done some research. That Ferris tool that we are going to go over, I worked on that project with him. This is also Gimignol and Camacho. So it's just showing you now that myofunctional therapy has demonstrated a potential effective treatment for snoring. Does everybody in the world know that? No. This therapy is like hidden. No one knows about it. No one's talking about it. Why? Because it doesn't cost that much money. It doesn't make that much money. There's no pharma is not connected to this. It's just helping the body, pushing the body to the right function. But soon we hope that it will be recognized as the most ideal initial treatment for sleep disordered breathing. Here's another very important article that showed how myofunctional therapy and obstructive sleep apnea, this was a systematic review and a meta-analysis. And basically here they had 9 adult studies, 120 patients. They reported their sleep study, their snoring, their sleepiness outcomes, and their AHI index decreased from 24.5 to 12.3. The lowest oxygen saturation improved from 83.9 to 86.8. And the sleep study snoring decreased from 14.05 to 3.87% of total sleep time. And the snoring also decreased in all 3 studies reported subjective outcomes. The Epworth Sleepiness Scale decreased 14.8 to 8.2. And the 2 pediatric studies, there was 25 patients that reported outcomes. The first study, 14 children, the AHI decreased from 4.8 to 1.8. And then the second study was evaluated, the children that were evaluated were children that were cured of obstructive sleep apnea after their surgery, their adenoid tonsillectomy, and also palatal expansion. They found 11 of the patients who continued myofunctional therapy remained cured, whereas 13 controls had recurrent OSA after 4 years. This is really important because the standard of care, when the kids go to the NT to be analyzed because they're not sleeping well, they're wetting the bed, they're moving a lot, their neck is craned back. These kids should all be evaluated for their breathing. They should have a consult for the ENT and a consult for someone, a myofunctional therapist, a PT that knows how to analyze breathing, a sleep pathologist, a speech pathologist, sorry. Those are the people that understand function, right? And what surgeons see, and God bless them, we need a team, right? But we also want to see what we can do to guide these children and adults, because I've had even adults getting tonsillectomies later on in life, how to deswell their throat. And it's possible. I did it with my kids, and I've helped many children through this process and their parents. So here is, let me keep going, the impact of a low tongue posture. So I hope whoever has sleep apnea here or whoever snores does not sleep on their back. Why? Because once you're on your back, the jaw just tends to prop open and the tongue goes down, and the path of least resistance is right through the top of the tongue. Because a lot of times people that mouth breathe, they already have turbinates that are nice and swollen and congestion, so they are more likely to stop using their nose and use their mouth. But their tongues, when you open your mouth, can fall smack right into the airway. One of the things we'll look at that not everyone is frenums, a short lingual frenum. This is from Dr. Kimonyo. So a short lingual frenum left untreated at birth is associated with obstructive sleep apnea at a later age, and a systematic screening for the syndrome should be conducted when this anatomical abnormality is recognized. What does that mean? Let me stop for a second. Brazil is the only country that it's a mandate before the baby leaves the hospital, they cannot leave without a tongue tie and lip tie assessment. And they basically do the frenectomies right there and then and there. It's this country that, and many countries, obviously, that was the only country that mandates that you cannot leave the hospital without it. And the majority of my patients that have sleep apnea or that need orthognathic surgery to reconstruct their face because their occlusion is all off, their airway is compromised, those patients, a lot of them are tongue-tied. But is everyone looking at that? Even the surgeons that are doing orthognathic, are they looking at the tongue tie? No, and I think that's one of the main reasons they develop that way. The low tongue posture, I'm going to show you a little puppet. So the low tongue posture, here's your palate. Now here's your tongue. Now it is not a coincidence that tongue fits perfectly up there, right? the tongue is a very strong muscle. As you grow and you rest your tongue up on the palate, it spreads this palate wide. If your tongue stays low in the mouth, this starts to happen. The palate starts to go up into what? The nose. So if you look in my mouth, my palate goes straight up. And I've done some adult expansion. Not enough to completely fit my tongue, but my tongue fits better in my palate. And what I want to do is make sure that you want to make sure the back of your tongue is supporting the back of the throat here. So this is a side view of your face. If you see where your tongue is, you should be having the tip of your tongue. Oh, can I ask everybody to get off on mute for a moment? I'm so sorry. I hear somebody.
Mute your phones, please.
Let me help you come out.
I don't think everybody hears it. Can everybody be put on mute for a moment?
So I'll just put it in. Thank you. Can you lift the seat up?
Okay.
Dr. Zagar, you can mute them as the administrator.
I'll just keep going. It's okay. So the tongue, when you are resting it up on the palate, and we're going to go through some exercises, the back of the tongue needs to be.
Hold on for a second. Let me see if I can
I
mute.
think it's someone named Sean, maybe.
Where can I mute it? How do I?
Go to participants. And then you can click as the administrator, like by the microphone, and mute them.
I see it. Larry, do you see what it is under participants? On the bottom middle left, if you go there, press there, I think it's Sean. The third one down, if you could just click mute. Oh, I think I can. I just clicked, I did it. I'll do it for you. Hold on. I'm putting a mute on everybody. Okay. All right, I think I did it. Okay, sorry about that, everybody. Okay, so the back of the tongue, you want the back of the tongue to support the back of the palate. Many people have the front third of the tongue up without a problem. But when this part of the tongue is down, this soft palate will drop into the airway area. So we're going to look at our Malampati and our Friedman scores soon to see how well you can see right through there to the oropharynx, to see if you can see under your uvula. All right, I'm going to share here. So ankyloglossia, let me go back. Ankyloglossia is a high risk for maxillary hypoplasia and soft palate elongation. So there's proof. This is one of Dr. Yoon and Dr. Zagi's work with Dr. Guimignol that show that a restricted tongue mobility was associated with narrowing of the maxillary arch and the elongation of the soft palate in this study. So that is one of the things you have to realize, is that the development of the craniofacial region with a low tongue posture due to a tongue tie causes changes in the craniofacial structure. So what is myofunctional therapy anyway? Like, what is that? And how many of you refer to myofunctional therapists? And do you know how they can help you with your patients? Not many dentists know about this. As far as, you know, I've met many dentists being in the city of Chicago for the past 20 years, and still not many know exactly what it's about. It's a 6 to 12 month program. And these patients, all my TMJ patients are myofunctional therapy patients. Anybody that's biting their nails or biting or clenching a lot, you know, those oral habits that we have are not keeping your tongue in the resting posture without any tension. That's what we want as a goal for our bodies, is to have our tongue resting naturally up with their teeth lightly meeting or lips slightly apart, or teeth slightly apart, lips relaxed and together, nose breathing using your diaphragm without any extra tension, not any, tension in the shoulders or the head and neck. This therapy will get you there. This is the therapy, I think, along with the head and neck TMJ therapy that we do in my office, that uses the hands-on skills to help these patients out of head and neck postures that cause stiffness, that are some patients kind of get stuck in a posture and need more hands-on care. We do an adjunct of PT with myofunctional therapy, but myofunctional therapy is basically mouth and tongue PT, and actually also airway PT. What does it do? It repatterns and improves the function of the oral and the facial muscles to eliminate oral habits. Prolonged thumb sucking and nail biting, tongue thrusting. Every time a person tongue thrusts, there's a lot of tension that goes through the TMJ and the facial muscles. Mouth open posture, poor oral resting postures of the tongue and lips. Tongue thrust swallow. I'm sure that you all look for these things in your dental office. Myofunctional therapists can actually help you restore these swallowing patterns to be normal in your patients. So these are just pictures of nail biting, thumb sucking, leaning, no leaning on your chin. No biting your lip. No biting your nail. When you start biting your nails, it's always the same position. That position will start changing your TMJ discs. Not a smart thing to continue doing. So the goals are nasal breathing. That's number 1. Lip seal. Number 2. Proper tongue postures. 3. Correct swallow pattern. 4. So basically, what is myofunctional therapy? It's learning how to use this vital center of your body, your nose, your throat, your tongue. You have to articulate well, you have to swallow well, you have to breathe well, you have to rest without tension. It's what we're supposed to do. But we start to change our habits because of allergies, stress. Stress is a big one, especially nowadays. But stress makes us breathe in our neck, right? In our chest, and sometimes your mouth drops, and then all this starts to happen in the face. So stress changes a lot in the way we use our body. Okay, so I'm going to go back here. So this is a myofunctional therapy kit. This costs about $69 at Myo Made Easy. And it has all the tools that we need to train these patients. And I get adults to do it as much as my children patients. So it doesn't matter when you do it, as long as you learn how to use your nose, to rest your tongue, and to swallow properly. Pretty simple. But they're really, silly exercises. We're going to do some of them here. Very silly. You're going to feel like, what the heck am I doing? But they work. They work with this area. They restore it. So here's the Malin-Potty score. This is one of the main things we look at when I analyze the airway of a patient. I'm actually looking to see, can I see under their uvula? How much? Here you can't see anything. All you see is soft palate. The only, like that wall that you see when you open their mouth, all you see is a wall of soft palate. And this is from 1 to 4 is just a worsening degree of collapse of the soft palate, collapse of the back of the throat. And what is this? This is actually a picture from Brian Palmer's website. You think that tongue fits in that mouth? No. So where's that tongue gonna go? Where's tongues go when they can't fit in their mouth, in the roof of their mouth? They go down and they start migrating towards the airway. So this is another thing we look at, is scallop tongue. So none is this one, and then this is severe. This is just the edges of the teeth making imprinted marks on the tongue. And what does that do? Like, all it's telling you is the tongue doesn't fit, and they've got, a lot of patients have it braced against they kind of end up pushing on their teeth or even sucking on their tongue a little bit, but their tongues don't fit without the compression of their teeth around it. And I'm guilty myself. I don't fully have tongue space myself because I'm a bicuspid extraction case, and I always have a little bit of biting of my tongue because it's too big in my mouth. So the ideal tongue posture, the suction tongue up to the roof of the mouth. This is where you want to be. What does it do? It helps support the back of the soft palate here to stay lifted. Now, what does a low tongue posture do? You'll see that the low tongue posture, you have a gap here. This gap starts to create a void, and this has no support anymore, so it starts to fall down. And the only way the tongue goes is down and back. Really, that's the pattern. And the principle of proper tongue posturing or positioning, the tongue should be completely at the roof of the mouth to maintain the optimal airway function. So here is the back of the tongue. This is like looking from the back molars forward. You want to fill that whole oral cavity with tongue. And this is the majority of my mouth breathers look like this with their molars, their intermolar space is sometimes a lot less than their lower jaw because their tongue's never up there spreading this space wide. So and here I actually want you all to try this exercise because to get the back up, it is tough, especially if you're narrow, right? You want to try to kind of force it up, and I'm going to teach you. I want you to say the word sing and feel how the back molars are, like the tongue is going between the back molars. Say sing and keep that tongue up in that position. So say sing, and you should feel that it's pushing up, and then with the tip of the tongue go up to the end position. So I call it the sing end position. So you say sing and close the mouth. So this is what it should look like at the end. You should look like it's, when you say sing, the tongue is up here between the back teeth. And then when you say N, it goes up here. So you want the whole tongue to be up. That's really the goal. So here are some goofy air opening exercises. So here's your mouth. You've got the uvula there. The soft palate is all muscle. So we want to activate these muscles in order to lift that airway, right? We want to activate and create some exercise for those muscles because those muscles get really weak and they just kind of hang out. So this is the first one, and you can laugh at me, it's okay. You say arc, onk. So those goofy sounds. And I do it every morning, and right when I brush my teeth, I'm doing my airway exercises because that's when I remember to do them. So I say arc, onk, arc, onk. And people say arc, unk, and it's not the same. You got to exaggerate. You got to get that soft palate to raise. You want to activate it. So another goofy sound that activates the soft palate is the caw. So it sounds like a crow. Caw, caw, caw. All that's doing is raising the soft palate and lowering and hollowing out the back of the tongue goes down. So you want to just try to open up that space. And then you can say g, g. So the back of the tongue goes up and down, which that's the place that gets really weak and lazy is the back of the tongue. So it looks like this, g, 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 g. And then I'll say, try to hollow out your throat with this sound. Like you say hawk. When you say hawk, like hawk-a-loogie, you try to hollow your throat, say hawk. And I hesitate and I wait and I try to open. Hawk, hawk. You can see my little uvula up there raising. You want to look in a mirror, and like every morning I look at my airway. I'm like, oh, thank goodness it's there. I'm happy. I'm not snoring. That's good. So I look. Can I see the back of my throat? Yes. Can I see my uvula? Can I see under it? Oh, good. Here are my airway exercises. So I just go on my way. And okay, so those are the sounds. The first 4 are sounds. Very important sounds. And if you're in a car a lot, do it in a car. Nobody needs to know what you're doing. All right, these number 2 and 3, I like to combine these two. These, I'm trying not to give you so much because realistically, people aren't going to do a lot of exercises. You know, like if I give 3, people tends to do them, but if I give 20, they're not going to do any. So the tongue, point, and trace in the waggle spot. So this is the tongue point. This tones the tongue. This gets the tongue, the sides of the tongue in. So you tongue point, and it looks like a lizard. I'm going to go side view here. You point it, and you want no touching of the tongue to the lips or the teeth. So it has to be space around it. So smile a little bit, smile big, and stick it out. And then hold it there for good, at least 5 seconds. It's really supposed to be 10. And then without moving your jawbone, keep your jawbone still. You're gonna move that tongue. This is to disassociate the tongue and the jawbone. When you're tongue tied, it's hard, but you can still try. Stick it out. Up on the spot, and draw a line all the way back to the uvula. And you hold it there, hold it there, hold it there. Everybody try that. Even if you don't, I normally train people in my breathing clinics and I see everybody's mouths and I check to see if you're doing it right. But if you stick it out for 5-10 seconds, it tones the sides. If you move it right, left without the jaw shifting, you've disassociated the tongue and the jaw, which is really healthy. You put it on the spot. In myofunctional therapy, the spot is right here, the incisal papilla. Draw a line all the way back to the uvula and hold it in your mouth. And I try to open my throat. I try to retract my tongue. And I hold it there. That one is awesome. If you want to do one for airway, do that one, that drawback. I like to combine those. It's like 4 exercises in one. Okay, and then the last one is the cave. And I think this is probably one of the most popular exercises. And if you ever see a patient that has like a lot of, like, for example, my dad, he's got a lot of skin here, just a lot. And a lot of my patients that are tongue-tied, my whole family's tongue-tied because of my dad. And my kids were tongue-tied, my sister kids, everybody's tongue-tied in my family. My dad and many patients that have a lot here are tongue-tied. So look at that. But to start firming this up, because if you're a woman, by the way, myofunctional therapy is like a natural facelift. It lifts your face. It actually is very healthy for your muscle tone in your face. You can suction up. And you cluck. So a cave is when you suction your entire tongue to the palate. So a lot of people have the first third in the beginning up, but you want like a web. You want a web shape right around your frenulum. Okay, so that exercise, it helps stretch the tongue from the floor of the mouth. It also helps the tongue be flexible in the mouth. Low tongue posture patients don't have all the flexibility. Like the tongue is supposed to create a ball of food, supposed to clean your teeth, supposed to articulate, supposed to swallow properly. But when your tongue's tied and it's tight and it's weak and it's lazy, it doesn't function well in the mouth. You want that tongue to fully function so that you can eat properly, swallow properly, and articulate properly. All right, so let me keep going. All right, so this program I mentioned before that I did with my children, I do with many, many adults, many children. It's meant for children, but it's simple, and I love it because it's so simple. So Simon Wong, he is from Melbourne. I think he is practicing in Melbourne. And Sandra Khan, they partnered up together. Simon was the inventor of this program. Sandra just got it on an app. And now I'm one of the reviewers, one of the few reviewers in the States that reviews anybody that has a child that wants to work on posture, tongue posture, and swallowing. You can do it through a phone. I have 4 children that I'm working with right now that it's hard to get children in the clinic. So it's so perfect to have this type of thing, because especially nowadays with COVID, it's like you can really help your child from just your phone, and the parents have to be totally vetted. But there's 3 exercises: chewing and swallowing, reading, and counting out loud. Compliance is good because basically they get 5 stars if they do everything perfect, and you want to kind of reward them by prizes. So, children always, they're motivated by prizes. There's Sandra, and she's actually the author of Jaws. Jaws is an excellent book that it kind of explains more for children. The book that I want to share, Breath, I'm sure everybody, if you haven't read Breath, James Nestor's book, I think I have it here. This book, you need to get this book. And if you're interested in watching my YouTube video interview of him, it's a book that, oh man, it just, people don't want to listen or hear much about breathing because they kind of all think that they do it fine. But when someone outside of the field starts writing about all the things that patients come in complaining about, they want to listen. Well, this journalist worked with some ENTs at Stanford and plugged his nose with silicone plugs with one other person, and it caused sleep apnea after just a couple days. He didn't have sleep apnea before he plugged his nose, and it caused sleep apnea because he was 100% mouth breathing. So just know that that book is out there and it's amazing. It really is. It has all the different breathing styles. It's not just Buteyko, it has many. So it's kind of a non-biased book. I really think it's worth reading. Okay, so the GOPEX exercises, let's just go over a couple of them. The click, click, close. This is how to find oral posture. Click, click, close. So you start clicking a little bit in your mouth. And then close your mouth. Gently suck the tongue up on the palate. Relax your face. Sit up tall. Feet planted. Don't crisscross your feet. And here's the thing. Who sits up? I would say 5% of my patients sit up. Everybody's slouching. Everybody's back is slouching. So we'll go into that in a second. N close. So say the letter N. Say N, and then close your mouth. And then suck the air above the tongue just a little bit. And then in that position, I'm going to stop share real quick. In that position, so you're saying N. This is the side. This is, don't touch teeth, but up on the palate. And then close your mouth and gently suck the air above the tongue. And now the tongue push-ups, practice pushing up, holding for 6, and release. Push up, hold for 6. That's another way of practicing this tongue posture. All right, so let me share my screen. All right, so this is, and don't laugh, my hair is kind of crazy there. This is in Valparaiso, no, Viña del Mar, Chile, a couple years ago when I was there training with my mentor, Mariana Raccabato. Can you see that, Larry? So what am I doing here? I'm counting in this posture. You see that posture? So hips are at 90, knees are at 90, hands are on my thighs. I'm in this erect posture. I'm counting out loud, but counting is not the point. It's the pause. The pause is where you rest your tongue, right where we're talking about the good oral posture. In between each count of 60, you have to find that posture. And you don't go to the next number until your face is relaxed. I feel the back of my tongue is supporting the back of the throat. So each time I'm saying the number, my mouth goes back to that posture. So it's 60 reps of that posture. And you get to breathe only on the 5th count. So it starts to reduce your breathing rate. And it's all through the nose. So I'll go back. This is an Apnear in Chile.
7, 8.
So mouth closed. It's kind of delayed. Sorry, guys. So I'm not sure why it's so choppy, but anyway. So that's the one exercise. Then I'm going to show you one more. This is a chewing exercise for my daughter. Oh, no, that's not it. Sorry. Okay, so she's chewing an apple. I'm going to go back and share. Share screen. This is what I get sent in a video through this app on the phone. I have someone that I'm working with in Argentina. I mean, it's kind of crazy, but they have to sit in this perfect posture. And kids don't know how to sit. It takes forever to get them to learn that. They're chewing with their mouth closed on both sides. They're creating a ball of food. And then they wait and pause. And you notice she just swallowed, just there. So she's going to do it again. So I'm going to go back for a second. This swallow. I'm going to let it go. It's kind of interesting, Larry. It's a little delayed. I'm sorry the video didn't come out as good as I wanted it, but I'm going to stop share. So the point of it is to have children or adults that never learn this, learn how to chew on both sides, keep their mouth relaxed but together. I have them practice creating a ball of food, a bolus. They actually show me their ball. It's kind of gross, but they show me their ball, and sometimes it's all over their mouth and it's not concentrated in one little position. I have them put their finger up. After they're all ready, the ball's in the middle of their tongue. They put their finger up, 1, 2. They point to their throat. And I don't know if you can see this, but I'm going to swallow without any lip contraction. So when I first start with these patients, kids or adults, their mouths are all these dimples come out. And you swallow 1,500 to 2,000 times a day. That eventually will give you TMJ issues later on in life. And the last exercise is reading. Reading, you know, if you ever, I present a lot. So I had no idea I was sucking in air and blowing out air all day talking. And I teach and I treat and I like to be with people, but you need to use your nose to breathe in between. And this very simple exercises teach you how to do this. And if you're interested, just get the GOPEX book on Amazon. It's $20. That program, it tells you exactly how to do it. Hang on a second. We're going to just do one more. Okay, so this is the reading exercise.
Reading out loud is an excellent practical application of this process.
Now she's breathing
It only
at all the periods
5 to
through her
20
nose.
minutes each day, reading out loud and punctuating each sentence correctly, with each comma a full stop. Remember to pause with your mouth fully closed in a completely closed position, and breathe only through your nose.
So that is one of the things that I don't think a lot of people realize, is that they're mouth breathing all day talking. Like, there's some patients I say, stop talking, listen more. You're blowing off way too much air. So one of the things I train, I teach people breathing techniques. I put a little capnometer on them, and that's when they get it. When I show my scores, their scores of really low CO2, where you exhale too much out. Now I got to breathe through my nose. I used to just suck in the air through my mouth, and that's very commonplace. If you watch any of the newscasters, they all do that. You hear, anytime you hear breathing, it's not good to hear breathing. It's really bad to hear breathing. Breathing should be silent. Okay. All right. So let me go back to the presentation. So the GOPEX, I can't tell you enough how amazing this program is. There's my son doing it. That's the posture you teach children. What child doesn't need that posture? These children are all slumped over phones and iPads. Their necks, their airways and their necks, I'm really concerned. This is an article that just shows that there's a lot of weakness in the tongue for mouth breathing children. This is the look of a mouth breathing child, that really, really flaccid look in the lips. But these are all the different compensations that occur with mouth breathing. The tongue position is integral in the development of the maxillary morphology. So a high arched palate equals a narrow nasal cavity. Now, not all the ENTs buy into this. I've talked to several that think that this is all like, there's no proof, and there's enough proof that when your tongue stays low and you get very narrow here, the only place that this can go is up, and you start bending a septum without any injury. There's so many bent septums, and people are like, oh, I can't breathe through my nose that well. Well, they need to either try the Buteyko breathing method to kind of use their nose, clean their nose, do exercises to unplug their nose, use their nose, or they get this done and then they do that. I did both, and I breathe so much better now than I did 10 years ago. Okay, we already talked about that. So this is a typical mouth breathing patient. If you look at her face, very long face, some cranial distortion, one higher eye on one side, very gummy smile, thick, I call this the luscious lip. The lower lip is always a little more luscious. It's bigger, high narrow palate, normally a tip and tongue and lip tie. They've got this slumped posture, forward head. Look at the spine. This is not a healthy spine, and she's I think she was 19, this girl. Recessed jawline. So that last presentation was all about what happens to the head and neck, right? And what happens to the mandible. There's a shift of the mandible when you lose the space in the back of your neck. Well, not only that, the tongue is attached to the hyoid that's attached to the sternum. So there's a pull backward if this head goes too far forward out of alignment. So there's a pull on the tongue to come back. And what does the tongue bring with it? The mandible. So these are all indicators of airway issues. Okay, so some of this I got from my colleague, Kevin Boyd, who does a lot of children expansion with the BioBlock. Any kind of crossbite, you got to think, oh, there might be an airway problem. That's an overclosed crossbite. All kinds of crossbites, midlines being off. this hyperdivergent facial pattern. So you got a very narrow face like we talked about. And you see this angle here? Last time we did the cone beam analysis at the last presentation, I told you that the mandibular plane, if it intercepts the skull, that's a cervical patient for physical therapy their entire life. Doesn't matter how old. This patient, you're going to have tension just because your anatomy gets you stuck there. Okay, so tonsils being hypertrophic, adenoids too, incompetent lips. I know that looks kind of like, you know, the models all have their mouth open and are all like sexy with their, not a good thing for any part of their facial development, and also not good for breathing. So you want this forward face growth. Indicators. So you've got this constricted, look at how crowded these teeth are. There's other teeth coming in and they're crowded. This is low tongue posture patient, not spreading their palate on their own wide. Grinding of the teeth. You see the inside of these teeth. That's an airway patient. Get a cone beam. Get educated. Learn I tell my patients, I'm like, go get one. This is a hidden problem. You're not going to know if your airway's compromised. It's a coffee straw instead of a Slurpee straw. Those teeth, they're just grinding away. Overweight child. So that forward head posture that occurs with the overweight child. Now, the pre-industrial revolution skulls are all nice and wide, not a lot of cavities. This is the modern day, nice and narrow. Everyone needs braces. Eczema, another indicator. The eye, those dark circles under the eye, the venous pooling, the overbite, right? You got an overbite. Retrognathia, the jaw setting back. Anything back, the airway is going to be compromised, right? So you don't want that. The tongue posture being low compromises the airway. The being up creates more space here. Scallop tongue, tongue tie. This is an obvious one. They're not always so obvious, especially the posterior tongue ties. They're kind of stuck in the middle of their tongue, and unless you knew how to do this maneuver where you glove up, go under the tongue and elevate the whole thing to see if there's a posterior tie, you'll miss it. The septum, is the septum bent? There's the septum again. How do you assess for a tongue tie? My real simple way of assessing, you want to ask the patient to lift the tip of their tongue. I ask them to open super wide. So I'm going to stop share real quick. Open really wide. And I measure that, right? You measure the opening, the regular opening, and then you measure open wide, tongue to the spot, the incisal papilla. And I've been released, so I had a tongue tie and I've done therapy afterwards, but a lot of my patients, they open and their tongue is like in the middle of their opening. So that's one easy way. And you also want to see how wide they can get with the cave. So I can put 3 fingers stacked on top of each other. But when I first did it, I could, when I first realized I was tongue-tied, I could put 1 finger. Okay, so that's the difference there. All right. I'm going to stop 1 second and we're going to do one more share. And if it doesn't, I'm going to stop for a second. If this looks like it's slow because of the Wi-Fi, I will stop. Hang on 1 moment. Okay, here we go. This is called
Just a few hundred years
Right to
ago,
Grow.
the human face was different. It was forward grown. Her wide profile and large dental arches ensured straight teeth and room for her tongue. Most importantly, she had plenty of space behind her upper jaw so she could breathe through her nose with ease. The modern face has changed. From childhood, her dental arches are less developed, crowding her teeth and giving her less space for her tongue, which impacts her airway. Many believe this stems from a number of causes, such as allergies that affect breathing. Another is the poor nutrition and softness of modern diets, causing toddlers to have underdeveloped chewing muscles and smaller dental arches. Because her upper jaw is too far back, she will struggle to breathe normally through her nose. To get more oxygen, she will compensate by opening her mouth to breathe, bringing her lower jaw down and back, creating a downswing of the face. This is how her undergrown upper jaw creates the appearance of buck teeth. She's actually compensating in order to breathe. If not corrected, the problem carries into adulthood. Extractions were documented in the 1600s as a way to treat crowding. Although they are a quick fix, they don't treat the problem of underdeveloped arches and have been implicated in harming the facial profile, making them the subject of much debate even today. In the 1800s, orthodontists in favor of extraction were looking for more effective ways of pulling teeth back, and this is where the story of headgear starts. Not understanding the cause, those orthodontists believed in a myth that in buck-toothed children, the upper jaw was overgrown. They thought that if they restrained its growth with headgear, the lower jaw would catch up and the teeth would line up. Although studies done throughout much of the 1900s have shown otherwise, this myth became a part of the foundation of conventional orthodontics. First, studies have shown that headgear suppresses the growth of both jaws, causing them to grow down and back into the airway, creating a clockwise rotation of the lower third of the face. The industry coined these deformities the headgear effect. The growth changes caused by headgear carry on into adulthood. In order to breathe, she will slouch her head forward to prop open her airway, creating a lifetime of neck and back pain. This is the infamous forward head posture. A simple physics diagram shows that the growth stunting forces of headgear pass right through the skull. One study showed that headgear caused an abnormal rotation of the sphenoid bone, and no study has examined the impact of headgear on the skeletal blood flow and nerve pathways of a growing child, or its long-term effects. Having a healthy airway is crucial to the survival of life, and especially so during sleep. When muscles around the throat relax during sleep, a healthy airway stays open because the tongue is sitting forward and has enough space to be suctioned up against the fully grown palate. With underdeveloped jaws and dental arches, the palate is too small for the fully grown tongue, which is sitting back to begin with. When she sleeps, her tongue does not suction, rather it falls back and cuts off her airway. This is obstructive sleep apnea. Like crooked teeth, it's a modern condition. However, it can reduce life expectancy. Not surprisingly, obstructive sleep apnea is marked by the same traits that describe the headgear effect. Both jaws are grown down and back, creating a clockwise rotation in the lower third of the face. If you have already been exposed to orthodontic treatment that caused the headgear effect, there are ways to reverse what happened. If your child wears a headgear or is exposed to an appliance or practice that retracts structures involving tongue space and the airway, his or her lifelong health may be in danger. There are plenty of alternatives to these practices, so make sure to get multiple opinions. The myth of the overgrown upper jaw that needs to be held back has long since been replaced with science. Science has shown that young children can be buck-toothed naturally, and that the lower jaw catches up over time with a fully developed upper jaw. Essential to this is nutrition, the use of chewing muscles early on in life, and good breathing habits. This means breathing through the nose with the mouth closed and the tongue resting up against the palate. Also, the practice of maxillary expansion has been shown for over a century to correct crooked teeth and improve nasal breathing space. And since 1918, orofacial exercises have been shown to correct mouth breathing habits. There are better ways. Right to Grow is an organization dedicated to ending the practice of orthodontic growth stunting. Please sign our petition on.
Okay. I love that video. I think it says it in a very simple way to understand. I show a lot of my patients that. Anyhow, I feel like we are headed in the right direction. I'm going to give you now, we're just going to quickly go over the Ferris tool. Larry, can you see Ferris 21? Yep. Okay. So there's 21 tests. And just so you know, if you go to ferris.org right here, you can get this. I think Larry also, Dr. Zagar sent you the form. But it's very simple. The first one, do the incisors show? Do you see teeth? Do you see a lot of teeth? What percentage of teeth do you see? Because the lips you want relaxed and together. You don't want them parted like this. This is just more degrees of teeth showing. So 1 through 4, you'd end up circling the picture that best matches what's going on with that patient. You need a flashlight, a timer, and a ruler, a millimeter ruler, and some tape. So you have number 2, mentalis strain. With the mouth relaxed, note if the lips are parted. If so, ask to touch lips together and watch for chin dimpling. So here you'll see chin's very natural and relaxed. Here the lips are together and there's a little tension in the mentalis, even more dimpling here. And this person has developed with a total mouth open posture. And now when he or she, it looks like a she, brings her lips together, there's a lot of mentalis strain. So that just meant she grew, her craniofacial development grew, and she was a mouth breather. So when you breathe with your mouth open like that, it will take a lot of effort to close it. And you don't want effort when you're resting your mouth in resting posture. Next one is the whistle. Ask the patient to sing, to whistle Old MacDonald Had a Farm, something like that. How easy, loud, and clear and crisp is it? If it's somewhat difficult, then you'd circle there, very difficult, and if they're not able to whistle. So whistling and like that control of the mouth with whistling is one of the measuring objective findings here. So here, the nasal breathing tape test, you're going to actually measure 3 minutes worth of nasal breathing. And you want to have them circle here, what degree of difficulty did they have? So during that time of nasal breathing testing, I end up doing this test. It's called the hypermobility Baton scale. So I'll stop share real quick. When I tape anybody, I'm just letting you know, this is actually 3M transport tape. You can use paper tape. It doesn't really matter, but I will tape them like this. I always put it in the back of their hand and then put it here. And then while I'm taped, they're taped, I start the timer for 3 minutes. And then I will see the Baton scale is, there's 9 points. The majority of my TMJ patients tend to be hypermobile. They're very loose jointed people that the discs start to slip out because their posture is bad and their mouth breathers, or their tongue is low and their chest breathers. So you want to see, can the pinky go to 90 degrees on both sides? Each of those are points. Can the thumb, if you flex your wrist, can your thumb can be stretched to your forearm? And as dentists, I will tell you, if you find a patient and you test that one and they're positive, beware. Those are the hypermobile patients that if you open your mouth for, dental work procedures and you didn't know that they were very loose jointed, at the end of the procedure, they might have a slipped anteriorly displaced TMJ disc. Those you got to be careful, do bite blocks and give them breaks in between. But I warn those patients to tell their dental hygienist, their dentist, I need a little break just to close my mouth so that it's not open for an hour. So some patients just want to open more for you. And if they have TMJ hypermobility, you do not want that. All right, so I'm going to go back to this. So I did, and then the knee hyperextension, if their knees go past 180, if their elbows go past straight, and then if they can touch their hands to the floor flat. And then here that's actually me doing different degrees of head posture. So where is the patient? You get them against a wall, have them lean against the wall and measure the space. My older patients have this problem that they can't get their head forward because their upper back is kyphotic. But you want to measure the distance between the back of their neck and the wall. When their head is back, are they looking up or are they looking straight? Then you have the Friedman score, which is the tip of the tongue against the bottom teeth. You open your mouth and you visualize your throat. If you see everything, you're a 1. And Friedman 2 is you can see the uvula, but the tonsils are not visible. The soft palate is 3 is the soft palate is visible, but the uvula is not. And 4, the hard palate is visible. Last one is on this slide is the scallop tongue. The normal tongue is no creases of the indentation of the teeth. Mild is a little bit, moderate's more, and look at that severe. Then you have the Malampati scores, basically the same thing. If you can't see the airway at all, it's a 4. If you can see everything, it's about a 1. That's a normal score. Oops, sorry. Tonsils are the tonsils. You ask the patient to say, ah, you use a flashlight. Are the tonsils covering, do they cover 0% of the airway? No, they don't. That's a 1. 26 to 50% tonsils are covered here. 51 to 75%, or the whole, it's kissing tonsils here. Touch, teeth, and hold. So here you open your mouth and you place your tongue on the tip of the palate right behind the front teeth, and you measure that. We talked about that earlier. So we want to measure the range of motion of the tip of the tongue up. And this, you can see the different degrees of tongue tie here. So you want to measure the vertical opening with the tip touching. The suction tongue to palate, you can also measure that. You also want to see how much of the tongue do they have up. Is it 50 to 75%? Is it 25 to 50%? Is it just the front, or can they not do it at all? While maintaining the suction, you can measure that wide opening. The swallow, you take a sip of water, gather a little saliva. Can they swallow without a lot of tension in their face? Can they swallow without their tongues pushing out between their teeth? And then the intercanine intermolar distance, you want to measure pre-myofunctional therapy and expansion. We kind of monitor these numbers, but between the canines and between the molars, You know, for adults, I think it's 36 to 39 millimeters of tongue space that you need to not have the tongue feel like it doesn't fit. But those are the measurements. Then you have the profile. What kind of profile does this patient have? Is their jaw forward along the length of their plumb line here? Is their jaw back, even farther back, or is it a class 3? Jaw forward. The indicator line is a measurement that's from the tip of the nose to the upper left central incisor, to the anterior-most point of the nose. So you want to measure the tip of the nose to that upper left central incisor. And that will tell you how much that child, it's normally something that a lot of orthodontists and pediatric airway dentists measure the forward growth of the maxilla. The cheek lift, how well are you able to elevate the sides of your cheek? One side might be a lot harder than another. So can both sides lift easily? Is there mild difficulty? Is there moderate difficulty? Is there a lot of difficulty? They can't even lift it at all. How much time do we have here? Hold on. We have 10 minutes. So I'm not even going to do this part. This is just to show you that all this stuff is not new. All of these articles are from the 1860s to 1940s. And it's almost like we go through periods where it's forgotten. And like, there's so much controversy in this growth and development, and orthodontists not liking what people are saying around expansion. I don't know. I'm not a dentist. I'm just trying to help people breathe better, swallow better, and have better posture. But there's a lot of headbutting in dentistry. But this is not new. This stuff is 1920. The relief of nasal obstruction of orthodontia, a plea for early recognition, enlargement of the nasal sinuses in young children, signs of mouth breathing. This is from the mid-19th century, 1908. I'm going to keep going because I want to go over the sleep position. So we talked about wanting to have sleep positions that are healthy. How you sleep affects your work productivity. You want to make sure. This was me in a hotel, and then I'll show you what I do actually at home. Always a pillow under the neck, side sleep if you can. If your shoulder hurts, don't be directly on it. Lay back a little bit on your shoulder blade, but be half on, half off your shoulder blade. But being on your side is going to be much better for your tongue not falling into your airway. Notice I have a pillow that I hug and a pillow between my knees. Now at home, these are actually some tips. I try not to see any electronics for the last hour of sleep. If you can get into a stretching routine, I highly recommend it right before bed. Take a shower if you can. I like doing the foam roll exercises. This is me after my nasal septum surgery. So notice I have a wedge. Anytime I'm sick, I use my wedge. That wedge helps me breathe better. Then I have a medium size. I like the Brookstone side sleeper pillow. And I have two massive pillows that elevate my arm so my arm is relaxed. You want to make sure that when you sleep on your side, this space is filled, that you're not like this and you're not like that your arm is up like this, that you're not collapsed like this. This does not help your neck. You want kind of your arm up. So supported. I put two big pillows there to get my arm up. And hold on. Where are we here? And then this is a body pillow that I fold in half and I put between my ankles and my knees. Why? Because I want my ankle, knee, and hip to be on the same line here. I don't want my knees hitting each other. I don't want my hip to go into adduction. I want a neutral spine. I want my neck and spine to be straight without any bends. and my hips to be even. So that's how I sleep. And every night I wear a breathe right, every single night. Or, so breathe rights. You guys, if you don't sleep well, please consider this. I'm trying to move my, okay. Consider using a breathe right. And a lot of people just know when I use them, I'm a little bit like, you can't have any sweat here. Like right now, it's a little warm in Chicago, but you put it on right here and you hold it, push it down so it stays sticky. You don't want this to kind of come off. So all that does is it lifts the nasal, the sides of your nose up, right? Or you can use a mute or a nasal dilator. So that looks like this. So you just kind of put this in your nose. Kind of gross, I'm sorry. Get it up as high as you can. I use this when I bike. I bike to work every day. If I'm exercising, you know, the flow, when you breathe big, and that's another presentation we can do at some point for snoring and sleep apnea. If you breathe big, too much volume, your nose collapses, your airway collapses. So what does this do? It's saying, no, you're open all the way to the point where this little plastic thing stays, it stents you open. And for me, when I'm wearing my mask, by the way, I love these brackets. These are called brackets. They allow your nose to have space. And so I wear my dilator. I even wore it today when I had my first patient. Because why? Because you got a mask on anyway. I'm still compromised even though I had a nasal septum surgery. Just know that I'm narrowed because of my bicuspid extractions. And so I try to optimize breathing because I want to feel good and I want to be in a good head and neck posture. So not only that, I'm going to keep going because there's just a couple more slides. I hope it's not the first time you've heard this, but use 3M micropore tape. You get that paper tape. You put it in the back of your hand. You put on your lips. Now, Somnifix. Somnifix is another type of tape. And all this stuff does not cost a lot. If you don't sleep well, if you feel tired in the morning, try it. This is a Somnifix. This one's really good for any lady that is worried about their skin getting pulled off too much. It has silicone, but this one has a vent on it. And you can still suck air through here if you wanted to. You can still breathe. And then the newest of the new that a lot of my parents use, this is called Myotape. So Myotape, this is made by one of my mentors, is Patrick McNone. It's brilliant. It has a hole in it, and it's like kinesio tape. If you've ever had kinesio tape like brings things together, as you know, in physical therapy, you try to tape up a shoulder or neck. This goes around your lips, and it brings your lips together. I don't use this. This is actually the kids version. The adult version is just a little bigger. I use the cheaper tape because I've been doing it for 10 years. But you want to do it with a nasal dilator. Do not do it without one, please. And if you're scared to tape over your lips, use the Myotape. All right, so I'm going to, let me just see. There's the Myotape, and that's it. Okay, we made it, and there's like no time for questions, but we can entertain any questions if anybody has. I'm happy to stay on for a little bit longer. Larry, I can't hear you. Uh-oh, Larry, hang on, Larry, hang on. I'm gonna stop share. I'm gonna go to you.
Hi, can everybody hear me?
Yes, yes.
Okay. No, thank you. There's a lot of information you covered. And for those of you who just joined in or joined in late, this is all being recorded, and Dr. Hobson has a way of putting it on YouTube so everybody can watch it again or take notes or show your staff or hygienists. Something the Spears people mentioned about a year ago, that you can have a hygienist take a myofunctional therapy course and become certified in your practice, which I thought was an excellent idea for general dental offices, to help see these patients and maybe treat them, and young adults as well, or children. So that was something to bring up. The other thing is, everyone, my email address is Zager, ZAGERDDS78 at AOL.com. Just send me that you attended so I can send you CE credit. And also the first course was given, and that's part 1. There's a lot of information there for everyone to review as well. And that's also on YouTube. And our third meeting with Dr. Hobson will be on December 7th. Is that correct?
Yes, the Monday, December 7th, I believe.
Okay. And there are other people that I have, experts coming up on other topics, which I'll bring up after the third, when we're doing the third meeting. But I have a ENT, head and neck person that's going to help us diagnose sinusitis, when to refer, or how they treat it conservatively, also what type of antibiotics they use, for how long, and how to know, like I've seen several cases where sinus lifts have gone bad or all on fours, sinus problems, or endodontically treated teeth causing problems. So odontogenic causes make up to maybe 30–40% of chronic sinusitis. And when you have elderly people or people that are highly allergic or on anticoagulants, it could be a catastrophic event later on. So there are a bunch of things, other topics that are covering, that I hope will be very useful to your knowledge and practices as well. Go ahead, Jennifer, if you want to finish up or.
Yeah, no, so
yeah.
Just know that I think next time we're going to go over TMJ, how PTs evaluate the TMJ. Last time it was cervical spine. This was more airway. Now it's going to be TMJ. But if anybody's interested in like the breathing training, that's one thing that I have 3 different presentations that treat snoring, sleep apnea, asthma, chronic fatigue, headaches, cold hands and feet, things like that. That's what I've done to many dental groups, and it's not exactly like the breathing clinics I do, because the dentists don't all want to do the exercises. It's funny, like the people that are actually participating have these problems, so they want to learn how to get out of it. But I do teach it to the dentists, and some of them do the exercises, some don't. But it's been a pleasure. If anybody has questions, please, I would love to entertain any questions. If there's anything that you are curious about, or
See if you can unmute everybody. Is there a way?
okay, let me. Yeah, I think I can. Yeah, I'll just work. Yep, I'm slowly muting. I'm muting everybody. It's actually not working. It's not working. Unmute all. All participants, it says, are unmuted. So if anybody has any questions, you can also use the chat room.
I have a question. Do you find that people that have the very strong gag reflex usually kind of have sort of that airway breathing issue, or like need to train the?
I would say the majority of my gaggers are posteriorly tongue-tied.
Okay.
So they tend to, the one thing, when you're tongue-tied, what we recommend is softening the floor of the mouth. So I'll go in with gloves and gloved hands, and I will oppose the mylohyoid. I'll go under the tongue and oppose it and soften all of that. And then we'll stretch the tongue and we'll do tongue exercises. But I always recommend at least 4 weeks of myofunctional therapy before any release, but that tends to help the gag reflex. And we also do vagus nerve activation to calm down the cranial nervous system, and that helps the gag reflex too.
Thank you.
Yeah. Larry, I think you're going to have to unmute people because it's not letting me right now. And if anybody, you know, I've seen a lot of dentists in my practice. If anyone has a neck problem and they want me to help you, I will help you. I have a lot of therapists that are awesome too. So just know that if you're feeling some neck discomfort, that there's a lot you can do with, you know, physical therapy and postural exercises, and you probably have to do a little bit in your mouth too in terms of tongue posturing. But we see children, we see adults, and headaches, neck pain, concussions, TMJ, locking. If you had a problem with a patient and they locked up after your procedure, we help unlock them. The majority of our work is in the neck. It's the jaw kind of follows the neck. So we are here to help any of your patients that you need help with. So it's called Hobson Institute and Renaissance Craniofacial Group of Physio Partners. I merged with a company, and now we're in Lakeview and the Loop. And you can always reach me if you're interested in emailing me. This is my email, my website, my YouTube video. I post a lot of YouTube videos on breathing. And, you know, I'm always trying to lecture more. So if you have anybody that is interested in this type of thing, I love to lecture. So I love connecting with like-minded people. And yeah, so thank you for this opportunity, Larry. This was great.
Thank you for taking the time and energy. You are very enthusiastic about it. It's obvious. And I think a lot of people learned, as well as when you review this, I pick up a lot of other pointers that I missed or that need to record, but it's a wonderful experience for me, and hopefully it is for everybody else. So again, I thank you all for joining us, and send me your email so I can send you your